Okay, we're going to go ahead and get started. I'm going to go ahead and read the introduction. Good afternoon, everybody. My name is Victoria Lancey, and I'm the Rural Education Manager with the Michigan Center for Rural Health, and will be facilitating this program. I would like to welcome everybody to today's Pharmacy Grand Round on Cystic Fibrosis Management, Past, Present, and Future, which is brought to you by Michigan Center for Rural Health and the Ferris State University College of Pharmacy. Before we begin the program, just a few reminders. If you're logged into the webinar portion and have computer speakers, you can listen to the audio through those. If you're logged into the audio number, handouts are located on our website and for you to follow along. Our website is www.mcrh.msu.edu. Click on the education link across the top of your screen, scroll down and find today's date, and there you will see the presentation, the attendance forms, and the evaluation link. If for some reason you cannot access this, please send me an email and I can forward anything you need. Attendance forms need to be emailed, faxed, or mailed into the Michigan Center for Rural Health office. Evaluation must be completed within 2 weeks or by August 23rd. If you'd like to ask a question during the program, please type it into the chat box so you don't forget it, and the presenter will address it during the Q&A, or if it's pertinent to that during that section, I can say it to the presenter right then. Our speaker today indicates no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program, and with that, I'm pleased to introduce our speaker, Heather Durand, I think, or Gerard, I'm not sorry.
Durand, sorry, correct the first time.
Okay. Who is a professor and assistant department chair at pharmacy practice at Ferris State University College of Pharmacy, and she received her Doctor of Pharmacy degree at the University of Michigan in 1995. Dr. Durand is an ASHP accredited pharmacy practice residency at the Children's Hospital of Michigan in 1996, and a pediatric pharmacy specialty residency at the University of Michigan in 1997. She is a board-certified pediatric pharmacotherapy specialist with a clinical practice site in general pediatrics at the Bronson Methodist Hospital in Kalamazoo, and her areas of interest include infectious disease, antimicrobial stewardship, cystic fibrosis, and immunizations. With that, I'll hand it over to Heather.
Thank you very much, Victoria. I hope everybody can hear me okay and can see the slides okay. As she mentioned, if there are questions that are pertinent to the presentation at the moment, I'm happy to answer those along the way. Otherwise, we will certainly have time to do that at the end of the presentation. So today, my focus is going to be on the management of cystic fibrosis, particularly focusing on where we have been in the past, where we are today with current management strategies, and where we're headed in the future, which I think is the most exciting part of the presentation that we will end up with, obviously, towards the end. Let's see if I can get these to advance here. Here we go. I have no conflicts of interest, as was mentioned. In regards to the objectives for the presentation, they are listed here for you. These are the things that you should be able to do by the end of the presentation. Rather than read through them, what I would like to do is just give you a moment to read over those really quick. And I've tried to, throughout the presentation, note when we get to a component within that presentation that relates directly back to the learning objectives by showing you the keys in the corner of the slide. But just in brief, we will be reviewing the genetics of the disease, the pathophysiology with the clinical manifestations that our patients present with. I'm going to be focusing a fairly large portion of the talk on chronic management strategies to maintain pulmonary health for patients with cystic fibrosis. I'll mention briefly some therapies we use for nutritional recommendations. And then, as I mentioned before, wrapping up at the end with the therapies that are most promising for managing this disease in the future. As many of you know, cystic fibrosis is one of the most common life-threatening genetic diseases that we see in the United States. It has historically affected mainly the pediatric population, but it is increasingly affecting adults, which we'll talk about more in just a moment. It was first described in 1938, and it does affect many organ systems in the body, most notably the lungs and the pancreas. But there are many other organ systems that we'll talk about as well that are affected, and I'll get into more detail about that in just a moment. With regards to how this disease is passed along from person to person, it is inherited genetically in an autosomal recessive fashion. So for those of you that need a little bit of a refresher on what that means, essentially two carriers have to unite and produce offspring. And when we see the recessive gene denoted by the small pink circle with the lowercase r, that is the recessive gene. And again, these two carriers would unite and produce offspring, and there would be a 25% chance that their offspring would have the disease because they've inherited both of those recessive genes. And that is the only way in which they can inherit the disease, would be to get two copies of the gene. There would be a 25% chance, however, that they may have a child who has two normal copies of a gene and they would be completely unaffected, but then a 50% chance of a child of theirs being a carrier. With regards to carrier status, it's known that in the Caucasian population, approximately 1 in every 25 individuals is a carrier of the cystic fibrosis gene. So as you can see, it's fairly common to be a carrier, at least in the Caucasian population, with a little bit less likely to occur in other races. What you can see on this slide here is the prevalence of disease itself within different racial groups, with Caucasians again being the most prevalent. Slightly fewer disease being seen in the Hispanic and African American populations, with very little disease being seen in Asians and other island populations. It's known that about 34,000 people in the United States are currently diagnosed with cystic fibrosis, and this translates to about 1 in every 3,500 births, which includes all races. That's just an overall prevalence rate based on live births. The data that I've shown up here for you is a little bit old, and some of the information may vary depending on the year in which this data is published, as well as the source of information. But in general, I really wanted you to just take away the trends in that cystic fibrosis does largely affect the Caucasian population more than other races. Throughout the presentation, I've embedded a few questions just to try to stimulate some thinking. So this is the first one that I have. Is this a true or false statement? Cystic fibrosis primarily affects children, meaning under the age of 18. Well, until recently, this was a true statement. I'm going to show you some data from very recent times that is showing that we are seeing definitely a trend towards CF, as I'll refer to it commonly, affecting more of the adult population. This graph comes from data from the Cystic Fibrosis Foundation registry, which is a computer database that they maintain for all patients diagnosed in the United States. And this came from their annual report from 2015. And what you can see in this graph is on the x-axis, patient age in terms of years, and on the y-axis, not only the number of individuals in the bar graph, but then a line graph showing the cumulative percentage of patients as the age progresses within the registry. What you can see is that at about the 50th percentile here, we see that half of the patients are under the age of 18, with half being over the age of 18. When we look at the actual age of patients reported in the registry from 2015, the median age was 18.6 years, with a range all the way from birth to 87 years of age. So imagine that there is actually somebody in the United States, at least in 2015, who has cystic fibrosis, who is 87 years of age. That's just amazing. So I think that what you can hopefully take away from this slide is that cystic fibrosis, while historically it has been a pediatric disease state, it really is becoming more of a disease of the adult population. Going hand in hand with that, we can see what has happened with the life expectancy of patients with this disease over time. Starting back in 1938, when this disease was first recognized, the life expectancy was under 2 years of age. Now, the data on this slide is a little bit old because it only graphs through 2010, but currently, the life expectancy for a patient today is more than 45 years of age. This slide comes from the CF Foundation, and it really outlines a few of some of the key points in time related to cystic fibrosis, not only history, but management of the disease that have led to the improved survival rates that we're seeing today. So starting out in 1938, as I mentioned, this disease was first characterized, and about 15 years later was when the first diagnostic test became available to identify patients with cystic fibrosis. And then a couple of years after that, interestingly, a group of parents came together and created the Cystic Fibrosis Foundation. This was not a foundation that was founded by providers, so it wasn't created by physicians, nurses, pharmacists, or any of the like. It was parents. And they wanted to create a foundation to provide support to the cystic fibrosis community. That has obviously expanded, and this foundation is made up of many, many, many individuals, including parents, caregivers, and healthcare providers. But at the time that it was created, patients were only expected to live till about age 5. You can see that over time, the life expectancy has increased and was in the teenage years in 1970, reaching 25 years of age by 1985. And what you can see from that point on, starting in 1989, there really has just been an explosion in not only the management of the disease because of new therapies, but also a dramatic increase in life expectancy. So in 1989, the gene that's responsible for causing disease was discovered by Dr. Francis Collins, who was a physician researcher at the University of Michigan. And this really opened the door to not only new therapies, but genetic therapies that we'll be talking about towards the end of the presentation. It wasn't until 1993 that the first medication was approved by the FDA to treat patients who have cystic fibrosis, the first special drug for this patient population. And of course, that drug is Pulmonary, which we'll talk about a little bit later, followed closely by the first inhaled antibiotic for this patient population, which was inhaled tobramycin or Toby. And then as you can see in 2007, where this slide ends, there were more than 30 therapies in the drug development pipeline for cystic fibrosis. And towards the end of the presentation, I will show you that there are many, many more therapies in the pipeline currently. So we will come back to some of this later on. I believe this is the last slide I have regarding survival, but I really wanted to just hit this point home with all of you to show that the predicted survival for this disease has really changed, especially over the last 15 to 20 years. So the median predicted survival age currently is 41.6 years of age. So what this means is that this is the age where 50% of the population with cystic fibrosis is expected to survive. The next point on the slide is a little bit maybe different, but still important nevertheless to understand, is that for a child born in 2015 with cystic fibrosis, their life expectancy would be 45.2 years of age if the mortality rates that we have today do not change. And that's just because of improvements in healthcare over the years. But if our mortality rates from 2015 do not change, from today, we would expect those babies to live until they're 45 years of age. But I think what you'll see that, again, towards the end of the presentation, when I talk about some of the newer therapies, that the life expectancy will probably be much higher for those children because of the new therapies that we have. They're very likely to change the mortality rates. So now let's get into what causes cystic fibrosis. And hopefully some of you recall some of this from school, but if not, I'll provide a brief refresher. As I mentioned, it is a genetic disease that results from a mutation on chromosome 7, and the mutation is in the cystic fibrosis transmembrane regulator, but that is a mouthful, so I'm just going to call it CFTR. The mutation is in the gene that encodes for the CFTR protein. This protein is responsible for chloride ion transport across epithelial cell membranes within different glands and exocrine ducts throughout the body, specifically the sweat glands, the respiratory system, and the GI tract. So what happens is when there's a mutation in the CFTR gene, it will lead to a mutant CFTR protein, and the mutant protein does not have the ability to function normally. So in a normal person who has CFTR protein in their cell membrane, the chloride ion, shown here in blue, will efflux out of the cell. Sodium and water will follow along with that. And what this does is it leads to normal balance of ions, and it creates a nice fluid mixture of mucus as well as other secretions outside of the cell, which allows the body to behave physiologically in a normal condition. For a person who has cystic fibrosis, this mutant channel either is completely absent or it doesn't function properly. So chloride ions are not able to efflux out of the cell. They stay inside. And so sodium and water also stay inside the cell. And what happens then is we get a buildup of mucus outside of the cell that is very thick and sticky, and it does not allow the body to work properly. So we have the pulmonary system that's affected, the gastrointestinal tract, and we also have the reproductive system and sweat glands that are affected. So what I would like to do now is just take a look at the protein structure itself and show you how different mutations in the CFTR gene will affect function of the protein. This diagram is just a little bit blurry, but I wanted to show it anyway because I think that it really shows you in a pictorial sense what's happening. Now this is on the left a diagram of the CFTR protein itself. It's a not large protein, but fairly large. It's 1,480 amino acids in length that encode for the protein. And of note, just interestingly, there have been more than 1,800 genetic mutations characterized in this gene that encode for the protein that can result in cystic fibrosis. So think about that, 1,800 different mutations. That's just mind-boggling. I think every time I look at the data, there are more and more mutations that have been characterized. Some of those mutations result in absolutely no function of the CFTR protein itself, while other mutations can result in some residual function. So there's varying degrees of severity, if you will, of cystic fibrosis, and it's all based on the mutation that people have. The most common mutation, which is what is shown here, is known as the F508 deletion, or historically called delta F508. This mutation is found in almost 90% of people who have cystic fibrosis, at least one copy of this gene. About 50% of people with CF have 2 copies of this gene, so by far and away the most common mutation. It is a deletion of 3 nucleotides at the 508th position, which is why it's called 508 deletion. And so it essentially results in 1 amino acid deletion within this protein structure. And that may not sound like it could be that dramatic, but in fact, 1 amino acid change results in a conformational structure of the protein such that it can't fold properly. And because it's not able to fold properly, the cell cannot process this protein properly, and this entire protein is unable to reach the cell surface where it is supposed to have its activity. So because of this just 1 amino acid deletion, a misfolding of the protein, this protein gets completely destroyed essentially, and it doesn't reach the cell surface where it has activity. For people that are homozygous for this mutation, it results in a very severe form of cystic fibrosis because, again, they have no protein that reaches the cell surface. Now, this slide looks very complicated, but I'm going to try to make it very simple. This shows you the different types of mutations that have been characterized within the protein itself based on the different genetic mutations that are available. And each mutation is classified as either class 1 through class 5. The class 1 mutations are also very severe. These are mutations in which there's no protein that's created whatsoever because there are stop codons inserted within the genetic material. And so the protein itself is just never created. A class 2 mutation, which is what I just described for you for the 508 deletion, is where the protein's created, but it's not folded properly, so it never reaches the cell surface, hence no CFTR function. And then the class 3 mutations are where protein is created, it gets up to the cell surface, but unfortunately the ion transport does not occur because the CFTR gate function does not work properly. So these first 3 classes of mutation are the most severe forms that result in disease of patients. Classes 4 and 5 are less severe. They are a result of either a faulty chloride transport, meaning that the protein is there and it's somewhat functional, but it isn't as functional as a normal protein. And then we have class 5 mutations where the protein itself is fully functional, but it just is not produced in large enough quantities as compared to people without disease. We are going to come back to this a little bit later when we talk about the new therapies that we're starting to see our patients be treated with. So to summarize the pathophysiology of the disease, we can say it's a result of a mutation in the CFTR gene. These patients can have either diminished protein numbers or absent protein and or diminished or absent activity. We know that the mutation results in reduced chloride ion transport across cell membranes, which leads to a lack of the sodium and water movement along with that. So these patients end up with thick mucus and thick secretions in their exocrine glands throughout the body, as well as very salty sweat. The reason for the salty sweat is that the sweat glands are designed to reabsorb chloride in a normal person. So if the chloride channel is not functional or it's dysfunctional, they're unable to absorb chloride as much as a normal person, and so they have more chloride and more sodium in their sweat. Now let's turn and look at the clinical manifestations of the disease. I think that most people are very familiar with the pulmonary manifestations, so we'll talk about those very briefly first. Lung disease and cystic fibrosis is what's responsible for causing death in about 90% of patients. Early on in life, they have very thick mucus, as shown here on the slide on the lower right. That thick mucus leads to the impaired clearance of secretions in the airway, as I mentioned. The lungs become colonized with organisms and they develop chronic infection, which we'll talk about more on the next slide. There's obstruction of mucus within the airway and resulting inflammation because of all the organisms that are within the airways themselves. This leads to air trapping. They can have areas of collapse within their lungs. They get mucus plugs, scarring of the lung tissue, and then over time, they can develop pulmonary hypertension and respiratory failure. Patients with cystic fibrosis typically lose 1% to 2% of their lung function each year. And not only is the pulmonary system affected, we have to think about the upper respiratory system being affected too. So many of our patients also have chronic sinusitis and nasal polyps. This slide is probably the second of what I would consider major changes in CF. We talked about earlier that we're seeing CF becoming more of an adult disease. This slide is showing you that we're seeing a change in the types of microorganisms that patients are chronically colonized or infected with. So historically, Pseudomonas aeruginosa was the most common microorganism that we found in respiratory cultures of these patients. But about 15 years ago, that trend changed. So if you see on this slide, the blue line, I don't know if you can see my mouse, but if you can, you'll follow along with me here that it was the most common. And over time, it has become less common than one other microorganism, which is Staph aureus. So about 15 years ago, we saw a flip-flop in the prevalence of these two bacteria. And that is thought to be due to the therapeutic management of the disease and the fact that we heavily target patients earlier in life. Once they're first found to have Pseudomonas in a respiratory culture, we aggressively treat them with antibiotics to try to eradicate the organism before it can chronically colonize and infect them. So that is thought to be the reason for the change here is new management strategies. Secondly, you can see that not only is Staph aureus becoming a major player, the orange line here is showing you that MRSA is on the rise. probably not surprising, as we're seeing much more of that in people without cystic fibrosis, but certainly in CF, it's becoming more and more of a player as well. And then lastly, the magenta line is a gram-negative organism called Stenotrophomonas multifilia. And this is notable mainly because it is a highly resistant microorganism and can be quite difficult to treat. Most of the other microorganisms have remained relatively stable over time. So going back to a few of the other organ systems, the GI tract is also significantly affected in many patients with CF, meaning that they tend to have very thick secretions within the intestine, and this causes malabsorption of nutrients and poor movement of food and digested material through the GI tract. So they can end up with obstruction and fecal impaction. About 90% of patients with CF have some degree of pancreatic enzyme insufficiency, and that's because their enzymes are unable to get into the intestine where they are supposed to work. And so those enzymes get stuck within pancreatic ducts and within the pancreas itself, and that leads to destruction and fibrosis of the pancreas. So obviously these patients can't digest food as well as they're supposed to, and they have malabsorption of their nutrients as well as fat-soluble vitamins. So they will often complain of abdominal distension, they'll have flatulence, greasy, fatty stools, and have difficulty gaining weight or perhaps problems with weight loss throughout their life. The damage to the pancreas can lead to poor islet cell function. So this can lead to problems with insulin secretion, and cystic fibrosis-related diabetes is the end result of that process. Some patients can also have damage to their liver caused by blockage of the biliary ducts, and they can have significant problems with gallstones. And then finally, from the reproductive perspective, it is virtually the rule that most males with CF are infertile because they do not have a vas deferens. And many females have difficulty conceiving because of thick cervical mucus, as well as some menstrual irregularities that they have because of malnutrition. There are many, many complications of the disease, only a few of which I've outlined here for you, most of them resulting from respiratory problems. I've talked about some of the GI effects, bone disease, where we see actually in many teenagers with cystic fibrosis. And then most of the other complications here are a result of chronic inflammation as well as malnutrition and malabsorption of vitamins. Moving on to the diagnosis of cystic fibrosis, I would just like to throw out another question. Of the 3 types of testing done here, which of these is the gold standard test that we use to diagnose the disease? Is it newborn screening? Is it sweat chloride testing? Or is it genetic testing? Well, I'll talk about what happened in the past. So starting not in the very long distant past, but before 2007 in the state of Michigan, sweat testing was the way that we diagnosed every patient with cystic fibrosis. Patients who developed symptoms of the disease, so they had to present with what we would consider clinical suspicion, so respiratory symptoms, malnutrition without other cause, perhaps a family history of disease, something of that nature. And then these children, if they presented during childhood, would be referred for sweat testing, where essentially a chemical is applied to the skin with an electrical current for about 5 minutes to stimulate sweating. The sweat was collected on filter paper for about 30 minutes and then analyzed for the chloride ion content. And if that chloride ion content was elevated, then that was diagnostic for the disease. As you can imagine, patients were not always diagnosed early in life because we had to wait until they presented with symptoms of disease. So in the year 2007, here in the state of Michigan, newborn screening became mandatory for cystic fibrosis. There are, of course, many other diseases and conditions that we look for with newborn screening, but CF was added to that panel in 2007. Just of note, this is now mandatory in all 50 states as of 2010. So Michigan was a little bit of an early adopter. Essentially, by screening babies for cystic fibrosis obviously we can identify them early before they even have symptoms of disease. So we can begin treatment earlier, we can make sure they maintain adequate nutrition and that they're growing and developing as normally as possible, and certainly we can provide support and counseling to their families. But what this testing involves is essentially with the dried blood spots that get sent into the state laboratory, they look for presence of an elevated immunoreactive trypsinogen, or IRT. IRT is essentially a protein that's produced by the pancreas that in cystic fibrosis can be elevated. So if this screen is positive, in and of itself, it's not diagnostic for cystic fibrosis, it's just a screen. So if it's positive, we then have to refer, or I wouldn't say refer, but we have to undergo 2 more steps. And those are shown here on this slide. So we have newborn screening, we have the elevated IRT. If this is elevated, those blood spots then would undergo a second tier of testing for genetic analysis. And in Michigan, we look for 60 of the most common mutations that can result in CF. And if any one mutation is found, that family is informed that they had a positive screen and that a genetic mutation was found, and their baby needs to be referred for sweat testing. And it would then be the result of the sweat test that would be considered diagnostic. This slide just shows you the sweat chloride testing parameters that we look for to determine if cystic fibrosis is likely or unlikely based on the test. So essentially the cutoff for being a positive test would be a sweat chloride concentration of greater than or equal to 60 milliequivalents per liter. Just a few statistics for you about diagnosis. Some of this comes right out of the cystic fibrosis registry reports, but in 2015, of all the new diagnoses of patients made during that year, about 60% of them were initially detected with newborn screening. That might seem like a low number, but as you can imagine, because newborn screening hasn't been around for more than 7 years across the entire country, there certainly have been individuals who were born with the disease that just probably because of some of the milder mutations did not present early on in life. I think what we're going to see over time is that more and more people with this disease will be diagnosed as a result of newborn screening. So that number will become much, much closer to 100%. Also, newborn screening can have some false negatives. So if the child doesn't have that elevated IRT at birth, then they would be missed by the screening. In the state of Michigan, at least in 2015, we had 19 new cases identified through this process, with 238 being identified since we started newborn screening. And if you see the number right next to that statistic, the 1 in 3,937, that's nearly in line with what we expect across the country, that 1 out of every 3,500 births is affected. We see that 1 in almost 4,000 is affected here in the United States, at least as a result of newborn screening. And when we look in the registry, just over time, nearly 70% of patients are diagnosed in the first year of life, but newborn screening does identify some of these patients much, much earlier than that. All right, I now want to shift gears and start talking about therapeutic goals. Obviously, we would like to optimize these patients' pulmonary function and prevent any disease progression over time, and certainly optimize their nutrition so that they can grow and gain weight appropriately. But I think that the one thing that's missing from this slide is the word cure. That's obviously what these patients want and what their families want, and what I think us as providers would also like. So we will be coming back to that momentarily. I do have a couple of web links embedded in this portion of the presentation that will take us out to the Cystic Fibrosis Foundation website. And I'm going to click on this one here because I want to show you, if you have an interest in this disease state and staying up to date on the guidelines or recommendations for treatment, that this is one really easy place to stay up to date on that. So this link takes us to the Clinical Care Guidelines site within the CF Foundation site. And if you scroll down, you can see that they categorize everything very nicely into guidelines for diagnosis, where here you'll see newborn screening, guidelines for taking care of nutrition and GI care, pulmonary guidelines, infection guidelines, and so on and so forth. So this is one really good website to have bookmarked if you have an interest in this condition. Before I get into some of the specific medications, I just want to make sure that everybody's aware of how CF disease is categorized based on severity, and that's really based on pulmonary function as defined by spirometry. So for a person to have mild disease, their FEV1 must be in the 70 to 89% of a predicted value. So for those of you that don't remember, the FEV1 is a forced expiratory volume in 1 second. So the patient inhales and then exhales as quickly as possible and as deeply as possible. And the volume of air that they would exhale in the first second is what is known as the FEV1. And there are values that would be established for a patient based on their age and based on their size. And so we can predict what a normal value would be. So if their FEV1 is between 70 and 89% of the predicted value for their age and their size, that would be considered mild pulmonary disease. For moderate disease, they would be between 40 and 69% predicted, and then anything less than 40% would be considered severe disease. So now looking at the two sets of guidelines I plan to cover regarding pulmonary function. This first set was published in 2013. It's an update from, I believe, 2007. These come right from the CF Foundation, and these are developed from multidisciplinary committees, this one including both nursing, physicians, as well as pharmacists. And basically what they do is they review all the published literature that has been out there since the previous guidelines, and they create evidence-based recommendations based on those particular studies. And so what they do is they then grade their recommendations. So a grade level of A would be considered a strong recommendation based on the evidence. A grade level of B would be that they recommend the agent for routine use. A level of C is consider the agent for use in a patient. A recommendation of D would be where they actually recommend against the use of that particular agent. And a grade level of I would be that there's just insufficient evidence to support the use, but they're not recommending against it. So this first set of guidelines addresses only patients 6 years of age and older. The next set was published in 2016, and these relate specifically to recommendations for preschoolers. So these would be kids between the ages of 2 and 5 years of age. And the reason that these came out is because there really was a gap in what guidelines were recommending. The ones that I just showed you were for kids 6 years of age and older. And then we also have some infant guidelines that I'm not going to be discussing today because there's not a lot of information in there about treatments per se outside of nutritional treatments. But there weren't guidelines specifically for the preschool age group. So these came out in 2016 to address that age gap. And again, these were evidence-based recommendations put together from a multidisciplinary group. And essentially their graded recommendations were using the same letters. Now what I would like to do is talk about the maintenance therapies that we are using a fair amount of today in the CF population and talk a little bit about what the guidelines recommend with these therapies. Before I get into the specific agents, I just want to note for you down on the bottom in the center, we have airway clearance therapy. These are different types of techniques that are recommended for all patients with CF to be implemented during infancy and continued throughout their lifetime. And the type of therapy, as well as the frequency of therapy that these patients use, is highly variable and really needs to be individualized. But they must be performed in conjunction with the inhaled therapies and some of the other therapies that I'm going to be talking about today. So if there's questions about airway clearance, I can answer those in the Q&A, but I really want to focus on the medications. So we're going to start off with inhaled tobramycin, which, as many of you probably are aware, has been around now for close to, I guess it's been a decade and a half, roughly, has been available, like I said, for many years and comes in many different products and dosage forms, which I have shown here. We have the traditional Toby, which is a nebulized product that was the first one really available for the CF population. It comes in a 300 milligram per 5 ml vial, as shown here. We also now have generic versions of the same inhalation solution, which are less expensive, but essentially the same formulation. We have a Catabis pack, shown on the lower left here, which is a generic version of inhaled tobramycin solution, but it's co-packaged with a reusable nebulizer device. In the lower center, we have Bethkis, which is a newer brand name formulation of inhaled tobramycin, but it's a little bit different from Toby in that it's only a 4 milliliter ampule. So what that means is it's more concentrated and it takes less time to administer this product. It takes about 15 minutes per dose versus the other forms of inhaled Toby that take about 20 minutes. And then the last one I've shown for you here is, I think, the newest, but this is the Toby Podhaler. So this is a dry powder version of inhaled tobramycin. It's kind of interesting. The dose that's required to administer to a patient is 4 capsules per dose. Each capsule would be inserted separately. So we'd start with a first capsule, load it in the device, pierce the capsule. It requires roughly 2 to 3 inhalations of each capsule to get all of the powder out of that specific capsule. Then that would have to be discarded and we'd have to insert the next capsule and repeat. So for each dose, 4 capsules. This might sound like a bulky technique to get a full dose in, but when all is said and done, it does take less time to administer a dose this way than it does with the nebulized versions. All of these products are recommended to be given twice a day during a 28-day on and 28-day off fashion, so that a patient can essentially have a month off of an inhaled antibiotic to try to help mitigate antibiotic resistance. These products are all fairly expensive. The generic Toby runs about $7,500 per month. And yes, I said $7,500, it's very expensive. Generic versions are closer to $2,000 to $3,000 a month. The Catabis pack is about, let me see if I have that one here. That one's about $5,000 a month. Bethkis is about $6,000, and unfortunately, the Toby Podhaler is the most expensive at about $10,000 per month. When we look at what the guidelines recommend, you can see that with their level of evidence, they've graded these very high. So for patients who have persistently positive Pseudomonas in their respiratory cultures, persistently positive being defined as more than 50% of their respiratory cultures over the past year being positive for this microorganism. So if they're persistently positive and they're 6 years of age and above with moderate to severe disease, it is a very strong recommendation that they should be on inhaled tobramycin because it has been shown to improve lung function, improve quality of life, and reduce the number of exacerbations that they have. There is actually fairly good evidence to support that even with mild disease in this age group, they can have a reduction in exacerbations. So it should be used in this population as well. However, when we look at the preschool age group, there really is a lack of study looking at the efficacy of inhaled tobramycin in preschool patients with persistent Pseudomonas. We do have some studies where inhaled tobramycin has been used for eradication, but that's not chronic infection types of studies. So there is a lack of evidence. However, the committee that put their recommendations together felt quite strongly that they could extrapolate the data from older patients with persistent Pseudomonas to this age group. And so they do give it a fairly good recommendation at a level of B that they should be on inhaled tobramycin. So now we're going to go on to the next inhaled antibiotic, which is inhaled aztreonam. And what you're going to see here is very similar information. The guidelines have fairly strong, or actually very strong, recommendations that inhaled aztreonam can be used, again, in those with persistently positive Pseudomonas, despite whatever their disease severity might be. Again, in the preschool age group, really no studies, just one study looking at eradication therapy with aztreonam. A couple of, I guess, practical points with this particular drug is that it's a little bit different from tobramycin because it has to be given in a 3 times a day dosing scheme, which sounds a bit like a disadvantage. However, it is a more efficient method of delivering this particular antibiotic because it has to be given with this specific nebulizer shown here, which is a high efficiency device that only takes 2 to 3 minutes to administer. So a lot different than the tobramycin that takes 15 to 20 minutes. So when all is said and done, it is less time throughout the day to use this particular drug. Unfortunately, this one is a little bit more expensive, and it runs at about $9,000 per month because it is only in a brand name product only at this time. Moving on then to another inhaled therapy, which is of course Pulmozyme, which has been around for a number of years, Dornase alpha being the generic name. Just as a refresher, this is a recombinant enzyme that breaks down DNA in the sputum. So patients who have cystic fibrosis have very high concentrations of DNA in their sputum from broken down white blood cells. This drug then actually chews up that DNA, and it is essentially a mucolytic. So the mucus becomes less viscous in nature, and it's easier for the patients to expel by coughing and through other clearance mechanisms. It's given either once a day or twice a day, depending on the patient's disease severity. And from a practical perspective, things to think about, because it's an enzyme, it has to be kept in the refrigerator. It does have to be protected from light, and it cannot be co-administered with any other medication in a nebulizer. So it has to be given by itself. When we look at the evidence for Pulmozyme, very strong evidence to support it's effective for many types of disease severity, particularly in patients 6 years of age and above, regardless of what microorganisms they have in their sputum. It improves lung function and reduces exacerbations, and in moderate to severe disease has actually been shown to improve quality of life. This is another costly medication, although not as expensive as what we saw with the antibiotics. It runs at about $3,000 per month currently, if given once a day. One thing I didn't mention here is for the preschool age group, you can see that the guidelines give this a level of recommendation C, meaning that there really is not a great amount of data to support its use from an efficacy perspective. The only thing that we have right now in this age group are safety studies. So the efficacy data has been essentially extrapolated from older patients. Moving on to another inhaled therapy, we have hypertonic saline. In this case, I'm showing you Hypersal, but there are other products out there. This is a therapy that was actually found through serendipitous use to be beneficial. It was noted that in Australia, there were patients with cystic fibrosis who were surfers, and they were found to have better lung function than patients who were not surfing. So it was theorized or hypothesized that it was because they were inhaling that salty ocean air, and that was helping them with their lung function somehow. Well, in fact, many studies support this finding and have found that inhaling a hypertonic saline does improve lung function. And so we do now have some FDA-approved products available. The studies that are out there are probably a little bit less convincing than with some of the other products that I've already talked about regarding their improvements in lung function and reducing exacerbations or quality of life, but nonetheless, fairly good evidence to support in older patients that hypertonic saline has some good benefit, although in the preschool age group, really another lack of study as compared to older patients. Hypertonic saline is usually given at least twice a day. It should be preceded in use with a beta agonist like albuterol to avoid bronchospasm and coughing that can occur. As you can imagine, if you're inhaling something really salty, your lungs might not like that very much, and that is indeed the case. So the more concentrated the saline, the more likely it is for them to have some bronchospasm. So we recommend pre-treating with albuterol. And even by doing this, some of our patients just can't tolerate hypertonic saline. So it's something we like to try, but unfortunately not everybody can tolerate it. Moving then to our last inhaled therapy, the beta agonists, from a chronic use perspective, which would be defined as anywhere from 2 to 4 times a day for at least 4 to 6 months. Unfortunately, there haven't been good studies to support that chronic use of something like albuterol has a lot of effect in a patient with cystic fibrosis. So some controversial studies, or I guess conflicting studies, some showing improved lung function, others showing not. Some showing a reduction in exacerbation, others not. So really no good evidence to support their use. I would have to say that for those patients who do have underlying asthma or airway hyperreactivity, definitely in the short term, these agents are very useful. And we know that, again, to prevent bronchospasm from other drugs, like the saline I just mentioned, of course, these medications are recommended, but from a chronic use perspective, just not a lot of good data. The one thing that I do want to say about these is that even though we don't have good data to support their use, chronic use is very common. If we look at the CF registry, almost 100% of patients receive beta agonists on a daily basis. So a couple of other chronic pulmonary medications that are oral would be azithromycin. And again, just a question, do we use it in this population for its antibiotic activity? Well, the answer to that is actually no. Azithromycin, as well as other macrolides, have been found to have some anti-inflammatory activity through multiple different pathways, which are depicted on this slide. But for time, I think I'm just going to skip over that unless there are questions later. There is some fairly good evidence to support that chronic use of azithromycin in patients who are older than 6, who have persistent Pseudomonas, can have improvements in their lung function, as well as fewer exacerbations. Some of the newer evidence is showing that studying azithromycin in older patients who do not have Pseudomonas can actually have fewer exacerbations, but unfortunately no change in their lung function. So this is a medication that can be considered in patients who do not have Pseudomonas. There's just not a lot of evidence to support that. And then we don't have any studies, unfortunately, in the younger patient population to show if azithromycin would have any activity or not. One caveat with this drug is if we are going to use it in a patient, we have to screen their sputum for the presence of specific types of mycobacterium to make sure they don't have those. If they are present, we cannot use azithromycin because this actually will create a lot of resistance with these types of microorganisms. The last medication that we see used chronically in some patients, although not very often, is ibuprofen. Just to show you here, there is some fairly good evidence to support its use in older patients with CF who have milder and maybe even some moderate disease, and that it can slow the progression of their lung disease. However, there are some problems with ibuprofen in that we do have to maintain anti-inflammatory levels, which means we have to monitor serum concentrations and maintain peak levels of 50 to 100. Because if we don't, there is some evidence in this population that we can actually make inflammation worse, and certainly we don't want that. So unfortunately, we have to use high doses, anywhere from 4 to 6 times the dose that we might use in a normal person that we might treat with ibuprofen for fever or for pain. We're using much, much higher doses. They do have to be given on an empty stomach for best absorption. So you can imagine from a tolerability perspective that the use of ibuprofen chronically just is not that feasible. And we actually have very few patients that take it on a chronic basis to manage their pulmonary disease. Now, before I get into the last maintenance therapy here, I want to just briefly review a few classes of drugs that the guidelines recommend against on a chronic basis for CF patients. And these include oral corticosteroids, inhaled steroids, and oral antibiotics that target staph. The reason for this, so these are all those level D recommendations, is that for the oral steroids and the oral antibiotics targeting staph, there is actually more harm than there is benefit. For the inhaled steroids, unfortunately, studies that have been done just haven't found these drugs to have any benefit whatsoever in this patient population. Now, despite these recommendations, there are about 40% of CF patients who do take inhaled steroids on a regular basis, and that comes right out of the CF registry. So I think that that's something we need to investigate a little further. I would be amiss to not at least just briefly show you some of the nutritional therapies that we use in these patients, but because of time, I'm not going to be able to spend too much more time other than just showing you that we do use these on a regular basis in most patients. So the last few minutes that I have, I want to spend talking about the future for CF. I said I was going to come back to the timeline, and prior to 2012, I would have to say that most of the therapies we use, in fact, all the therapies we use for CF patients are really for symptoms and to try to manage their symptoms and perhaps prevent things from getting worse, if you will. Well, now I think is where the exciting times come in that the new therapies that we have are really are what we would call modulators. They're modulating the course of disease. And they're really getting at the genetic mutations that these patients have and trying to correct them. So the first product that we have available is ivacaftor or Kalydeco. This became available in 2012, initially just for the age shown here with the specific mutation shown here. This specific age group and population of patients really is only about 4% of the CF population. So if you can imagine a drug approved for 4% of a population of, I guess, what, 34,000, whatever 4% of that is, a very small percent or very, very small number of people. But nonetheless, this drug was approved because of the impressive clinical efficacy that it showed in studies. Essentially, using this drug, and I'll show you the mechanism in just a moment, it improves the basic defect in CF by almost near complete restoration of the CFTR function. So I'll show you in a moment just how it does that, but you can see exactly what the end results of this medication are for this specific population here on the slide. We saw improved lung function in the studies of anywhere from 10 to 12% in their FEV1. And this is unprecedented. None of the other medications that we have used in CF can result in improvement like this. You can see the reduction in sweat chloride concentration of almost 50 millimoles per liter or 50 milliequivalents per liter. Again, that's almost just complete correction of the defect at the molecular level, resulting in fewer exacerbations, significant amount of weight gain, and increased quality of life. And the CF Foundation has actually made a statement that they believe in this specific mutation that this drug can increase their survival to 70 to 80 years of age. So what's happening here with this mutation? I just wanted to reorient you to the slide that for this G551D mutation, again, this is one of those gating mutations. So the chloride channel protein here is in the cell surface, the cell membrane surface, but it is just not functional. So what this drug does is, you can see on the left here, the channel is closed. It's there, but it doesn't work. The chloride ions are the red dots. On the right, when we use this medication, it causes a conformational change in the protein such that this channel stays open and it allows that chloride channel to work. So it potentiates the channel. It allows it to work more normally. This drug has now become FDA approved for down to the age of 2 in the CF population, and it has expanded to 33 different mutations instead of just the original 1 that it was approved for in 2012. Unfortunately, not all of these mutations are responding the same way to the medication, but we're still seeing some fairly dramatic correction in the function of that chloride channel. From a practical perspective, there are a few things just to note with this medication. It is given orally every 12 hours, and it does have to be taken with fat-containing foods. So we usually tell our patients to, take the dose with some cheese, eggs, peanut butter, drink some whole milk, something like that. So it does have to contain fat, and unfortunately there is some hepatotoxicity that can occur with this medication, so we have to monitor liver enzymes and liver function fairly closely, particularly early on in therapy. And then there are also some drug interactions to be aware of that, because of time, I won't get into right now. The last FDA-approved medication that we have is Orkambi, or lumacaftor ivacaftor, and this one was very exciting because 2 years ago when it was approved, initially. It was the first drug available for that F508 deletion mutation. Remember, again, this is the most common mutation that we see in CF. And it's approved for people with 2 copies of this mutation. So that was approximately almost, half of the CF population. It's now approved down to the age of 6, again, for the same mutation, 2 copies of this mutation. But unfortunately, it has not resulted in the same degree of improvement as what we saw with just ivacaftor for some of those gating mutations. So some lung function improvement, which is good. Some reduction in sweat chloride concentration, again, good. Fewer exacerbations and some weight gain, but comparatively not quite the same as what we saw with ivacaftor for those gating mutations. So what this drug does is it is used in that class 2 type of mutation, like I mentioned. Lumacaftor, what it does is it causes the CFTR protein that isn't folded properly to still be able to be processed through the Golgi apparatus so that it makes it to the cell surface. And then the ivacaftor would then potentiate that chloride channel to stay open so that we do get some chloride ion movement across the membrane. Because of time, I'm not going to spend too much talking about this slide. You can ask questions about it if you have them. But I guess what I wanted to point out is that we are seeing more and more patients being prescribed these drugs according to labeling. Unfortunately, they're very expensive. You can see the cost here. Insurance companies are paying for them, but they do require prior authorization, and you do have to get them through specialty pharmacies. So the last few things, I know we're running out of time, but I just want to mention where we're heading. The future of CF is very, very bright. We're in the modulator era, and hopefully, as I'm showing to you, that some of this data is very exciting. I think that these are game changers. There are multiple different types of modulators in the research pipeline. Modulators that are focused on more mutations, and modulators that are much better at restoring CFTR function than what we see with the ones we currently have available. It is expected that in the next 5 years, we will have therapeutic drugs available for 95% of CF patients that will be these modulators. So much more than, the about 55% of patients that we currently have a modulator for. Of course, we will have symptomatic therapies that will become available that will be new and will help us improve management, but they're not going to change the course of disease like what we see with the modulators. And then finally, genetic manipulation is something that, of course, would be the true cure for the disease, but that is definitely probably more than a decade away, perhaps even 2. I just have a couple of other websites here that, because of time, I'm not going to click on, but if you are interested in knowing what clinical trials are going on, you can look at the Clinical Trials Finder through the CF Foundation. And I believe there's over 130 trials ongoing that are sponsored from the CF Foundation, looking at different therapies for these patients. And then also the drug development pipeline. If you have an interest in seeing where in development certain agents are, this is a great website to look at as well. So in summary, we can say, I think that the landscape of this disease is changing. Patients are living much longer lives than they ever have before. They're being diagnosed earlier, in fact, many within days of being born. And we're seeing many more effective therapies, and certainly a lot that are on the horizon with the modulator era. We still have to manage symptoms for our patients. That's important, but I believe the future is very bright with these correctors, these modulators, and perhaps even a cure. So with that, I'm going to end, and I think we'll take some questions if there are any.
Okay, I'm going to unmute all the lines, so please be mindful if you are having a sidebar conversation about what was being said, or you can use the chat box feature. So all the lines are now unmuted, so please, you can feel free to ask a question, or you can use the chat box feature. Do we have any questions or comments for our presenter?
I just wanted to state that this was very informative, and I really appreciated your expertise.
Oh, thank you so much. I hope that it was informative. I don't know what everyone's backgrounds are in regards to cystic fibrosis or how commonly you see patients with this disease. So I tried to make it as practical as possible to show everybody just how exciting this time is right now in CF and all the research that's ongoing. It's incredible to go to the conferences every year and learn about, you know, how far we've come in managing patients with this condition. It's very exciting.
Well, thank you again.
Regarding question 13 on the quiz, I don't think that's something we covered.
I'll take a look at that. Thank you. Are there any other questions or comments? Okay, if there aren't any other questions or comments, we'll go ahead and let our presenter go. And I have fixed that one question in the quiz and evaluation, so you can go ahead and feel free to fill that out. We'll go ahead and let our presenter go. Thank you for joining us today, everybody, and have a great rest of the afternoon. Thank you.